Sorry about that. Okay, so let me start over. So first we're going to start out by overviewing what to expect at NACOR. Then we're going to do some compare and contrast of some pathologies that I often see mixed up. Then we're going to go through some images. And then we're going to look at some images and we're going to discuss what you would do, whether you would fit them with contact lenses, whether you would defer them, whether you wouldn't. And then we're going to look at some other images, and then you're going to tell me what that pathology is and what the sign, symptom, or treatment is for that particular picture. All right, let's move on. All right, so NACOR pathology, what to expect. So it's worth about 17% of the exam. They're going to give you a booklet, and inside of that book is going to be a series of pictures. 10 of the pictures, you're going to have to identify the pathology, and there's going to be 4 other pictures where you're going to have to identify the pathology as well as enter a multiple choice question regarding it. So you actually don't have to do like any explaining per se, but you would need to know the pathology and which answer would apply to it. All right, so on to compare and contrast. All right, oh, I forgot to delete it on this one. All right, so we're comparing and contrasting. So entropying is entering, so E-N-T, entering into the eye, and ectropion, E-C-T, is the one that is going out of the eye. And there are a lot of issues that can be resulting of that. So when you think about ectropion, what are some issues that you think might occur relating to ectropion? So that's your eyelids going out. Your eyelashes are turning outwards.
Trichiasis? Oh, sorry, that's with entropion.
Yes, and also with blepharitis, right? Because if you have a lot of blepharitis continuously, you can get trichiasis. Good call out. So entropion. So your eyes turned, yes, dry eye, sorry, yes. Yeah, so you can get band keratitis across your eyes. And then also you can have irritation and infection, right? Because you've got the eyelid that's exposed on the inside there. So some people can get continual infections. And sometimes, right, if your eyes are not closing, to overcompensate, you can have a lot of excess tearing, right, to try and compensate it. Would this be a good person to fit with contact lenses? I also read it was in, because it's, okay. I'm not going to say nay on that. I haven't read it either to the contrary. So if you read it and it's from an incredible source, then I'm sure it's correct. Sorry. In regards to ectropion, fitting with contact lenses, if somebody came in this situation and they wanted to get contact lenses, would they be a good person to fit for contact lenses?
No.
And why wouldn't they be a good person to fit?
The physiology of the eye is not required, is not suitable for the contact lenses.
Yes, and the contact lens is going to be exposed anyway, so it's going to dry out, right? Because our lids are always closing and keeping that lens moist, right? So if it's open, it's like that's almost like a lens that's sitting on the table. It's not going to last very long. Yes, and it increases in causes of infection. Very good. What about entropion? Would they be a good patient to fit?
Wouldn't it be good for them to have a lens in as a bandage?
I was just going to say yes. For bandage purposes, yes. But you also have to consider the fact of, so what is the purpose of your eyelashes, right? Like if you're just getting somebody to wear it for just regular reasons, that there is no actual integrity of their eye that's been compromised so far. Because your eyelashes and your lids, what's the purpose of them? Is to protect your eye and to prevent dirt from coming into your eye, right? Because the lashes they make the dirt go away. Sorry, somebody saying something, or is Victor, are you saying something? Can you mute if you're not saying anything? It'd be fine. All right. Yes. So in the case of bandage, but in general for just contact lens wear, because more dirt and debris is getting into your eye, not so a good idea. But for the purposes of a bandage fit, yes, that would be a good idea. Any questions on this one before we move on? We're still going to circle back to these items again. Okay. All right, sty. So we're going to be comparing sty, which is going to be an internal, external hordeolium, versus chalazion. So when you compare a sty to a chalazion, what significant okay, so before I get to that point, what causes a sty?
Blockage of a meibomian gland?
No.
That one, blockage is chalazion, so good job on that one. And sty is?
Because of the hair follicle as well, I think.
Yeah, it can be related to the hair follicle. Somebody put white pimple. What does the white represent? Just think about cuts in general when you think about white. If you see a cut and it's got white stuff on it, what are you thinking?
Infection.
Infection. Thank you. Yes. So sty, that's the reason why you see those are, because it is an infection. And depending on which area of the lid that it's in, it will determine whether it's internal or external. So when you look at all of these, you'll see that some of them you can see the actual infection that is there. And when you look at the chalazions, you can actually see that it's a blockage. If you look at them, they look more deeper and they're more smoothed out because it's deeper and more internal. And it's like with the chalazion, those are the ones that you'll often see getting bigger, right? Because it's such a slow growing and it's not necessarily painful until obviously it gets to certain sizes or if it gets infected. Whereas with the sty, those ones are painful. Right, can everybody see the difference between these two?
Yes.
So if you're looking at these, you can see the infection, they look more top level surface. And these ones you can see they're more of a blockage. All right, good. What about this one? So this is GPC. So which one would you consider to be a moderate case? First, second, or third? Going from left to right. So first and second or third?
Moderate first.
This one?
Yeah, you're asking if it's moderate?
Which one of these three is the most moderate?
3.
3 is the most moderate, yes. So that's very mild, right? Sorry, I think I confused you by saying the word moderate. I'm sorry. The most mild, yes. This one is moderate. I'm so sorry. That's what happens when you don't eat. And this case down here is severe, right? And so what are some things that generally cause GPC?
Contact lens solution, allergy.
Contact lens protein.
And how is the buildup of that protein generally there? It's usually from overwear of lenses. And so that buildup can create like a dirty contact lens over time. So it could be somebody's overwearing the lenses or they're not cleaning them properly, or and then adding on top of that, maybe they do have a lot of protein inside of there and then they're not cleaning it properly on top, or they're wearing the lenses slightly longer, then you can get like GPC infections. So next one. All right. Corneal ulcer versus a dendritic ulcer. So what you'll notice, okay, before I say what you notice, what do you notice is the difference between these two?
The one is dendrite, I think, is a fungi.
Hello.
Yes?
Can you see your lecture now?
Uh,
Dendritic ulcer is a form of herpes, and it's more of a
yeah, I
web-like
could see
appearance.
the lecture, but it's small.
Yes.
Part there you can click on to enlarge it. It should show a box,
Let me mute this person.
a
Just give me
bracket
one
on the
second.
left side and on the right.
There we go. Yes, you are right. Relates to herpes simplex. And yes, branch-like is the key
Which
thing.
one?
Oh, dendritic ulcer. Dendritic. So an ulcer, generally, it could be like a cut that was on the eye that now got infected, or any form of infection from relating to the eye. But dendritic ulcer, you will always recognize it by the branch-like features. And this one, you see they're like white patches generally. And sometimes they can be very, very big. All right, next one. Pinguecula versus pterygium. So how would you differentiate these two?
A pterygium usually starts to infiltrate the cornea towards the pupil, whereas a pinguecula usually stays on the sclera part of the eye, and it's more of a yellow color.
Okay, that's good.
Yeah.
Any other pterygium is over the
Pterygium
cornea.
is
Sometimes
like a
it has
blue.
to grow to that point, right? Yellowish color, yes, those are all good. So pterygium is more of a wedge-like, right? A wedge-like growth, so that V-like growth that's growing in. Whereas pinguecula is like, I don't know if you people from the BlackBerry days, ping, like a point. It's more like a one point centered. Whereas the pterygium is like I don't know why every time I hear pterygium, I think of tarantula. I think I have an issue with spiders, so I always think like web-like, but it's more of a V-like growth. And yes, though that's the one that usually grows over into the cornea, but it may not have necessarily reached that far in, right? Because sometimes you can just start to see the beginning part of that wedge-like growth. But you guys are all absolutely right, spot on. Great job. All right, corneal abrasion versus foreign body. What is the difference?
Abrasion, like a scratch, might be.
You're right, it is a scratch.
Yeah, it's a scratch, but foreign body is a existing something, I think.
Yes, something foreign is actually still there. And the reason why I say that is like, for example, this one here, it almost looks like a pin was stuck in somebody's eye, right? Or this one here, there was something that was there that actually created. So there was some type of foreign body that was there that created it, but it's no longer there. So if you see that image, that is a corneal abrasion because the object is no longer there. So now what you are looking at is the corneal abrasion. But in these images here, all of the images, so you can see the nail in the eye, you can see the piece of metal here with the rust around it, and you can see whatever that item is there inside that person's eye. Yes, Katie.
Can you only see corneal abrasion through fluorescein staining?
I've never seen it without it, but
Okay,
I mean, like
yeah.
all the images that I've always seen, it's always usually with it because then you can see the difference. I think it would be pretty hard to see without it.
Right, because
I
it's
can't think of any more where you can see with
transparent.
the word.
Yeah, that makes sense.
Yeah.
Okay, cool.
Yeah. On that point that you just said, what is the difference between fluorescein and using rose bengal? That you just brought to my mind. What's the differentiation between them? Yes, fluorescein is green, rose bengal, yes, the color. But other than that, there's a differentiation. So yes, who said that? Good job. Yes, Rose Bangel highlights dead and dying cells, whereas the corneal abrasion will highlight the disruption. Sorry, not the corneal abrasion. I'm sorry. This is what happens when you don't eat. The fluorescein will highlight the disruption and give you pooling and all the areas where it's no longer smooth. But Rose Bangel will highlight dead and dying cells. Great job. All right, radio cave versus keratoplasty. So first of all, what is radio cave?
Redirected.
Sorry, I couldn't hear you. Hi.
Sorry, I made mistake.
I think it's the old method of the laser. It's the very first method of the laser for the eyes for myopic. Very
Yes.
old.
Yes, so it could be myopia, yes. And so that one is no longer, it's pretty archaic, so it's no longer really used. And on the right-hand side over here, these are keratoplasty. What is keratoplasty?
Corneal transplant.
Yes, yes, corneal transplant. Great job. And so, and generally in the pictures, you'll see either like a Z pattern or some form of stitches. So you can see in this one, you don't see the Z anymore, but you'll see the stitches. And in this, and with the radial K ones, you'll notice that these ones have gone as far as so close to the pupil, and that's the reason why also there was an issue with it, because people had halo around lights. But with sorry, with sorry, you saying something?
No, nothing. Sorry.
Okay, with keratoplasty, you wouldn't have that, right? Because why would we stitch so far towards the pupil? Because then it would be invading inside the vision and it would be destroying the integrity of the transplant that you're actually putting in to be going that far. Any questions on this one before you move on? All right. Subconjunctival hemorrhage versus hyphema. Okay, so first of all, what is a subconjunctival hemorrhage?
It's like a bruise on the conjunctiva or under the conjunctiva, like the sclera, basically broken blood vessels that causes the blood to pool out into the underneath the conjunctiva.
Good job. And a hyphema?
When blood pools in the anterior chamber.
Yes. And so what would be like okay, no, we're going to do into treatments afterwards. I'm not going to talk about that. Great job. So always focusing and if you notice this one here, the pool is very small. And so whenever you look at an image, always look where the light is shining to see what that person is trying to highlight for you. Yeah, collection of blood, corneography, all great answers inside the chat, by the way, even for the previous slide. All right, basal cell versus squamous cell carcinoma. Okay, so and also melanoma. So which one of the three is the malignant one? So you've got basal. You don't have to write the whole thing out. You can write S, M, or B. Basal cell, squamous cell, or melanoma. Which one is the cancerous one? Excuse me.
Melanoma.
So melanoma is the dangerous one. Not to say that any of the other two cannot progress to it, but melanoma in of itself is cancerous. So when we're looking at the image here, the reason why I put this picture here is I want you to have a visual on what it looks like. So you can see the squamous ones are generally closer to the surface. And of course, as things get bigger and progress, they can go deeper. So it's not to say that it can't go deeper than that. Basal cell, a little bit more deeper. And then melanoma would depend on the stage, right? It doesn't necessarily have to be that, but it can go very far. And when you go to the stages, which we're going to talk about another slide, that's when like it gets to your lymph nodes area, that's when it becomes like major problems that can lead to death. All right, so when we are comparing the two, what do you notice? So this side over here is your basal cell, and these ones over here are your squamous cells. So what do you notice when you look at the two to compare them? Or do you notice anything?
The darkness of it.
So color can skew, but yeah, you're right. Especially in melanoma, those ones are generally brown. But yes, there can be variations depending on. So I wouldn't so much rank it by color. Melanoma, yes, by color, because that one's always brown. But I wouldn't so much rank these ones by color because you may end up getting them wrong. There's something when you look at the features of these. When you look at how, like, so when you compare all of these ones to these ones, do you see anything?
It looks like an ulcer. It's like a wound. It's different.
Which one looks like a wound? Different sizes, yes. So different sizes. Yeah, that can come into play.
The left one, yeah.
The left one, yes. So the biggest thing to notice between basal cell and squamous cell is that basal cells generally look flatter. Squamous cells, these are more elevated. See, even this one here, which looks disgusting and very large, it's still pretty flat. But all of these ones here, they're all raised. And if I go back to the previous picture, you'll see that basal cell is actually deeper. So hence the reason why it looks a little bit, I'm going the wrong way, sorry. Hence the reason why it looks more flat. So when you see the image, generally the ones that I've seen in pictures are usually either basal cell or squamous cell. I mean, yeah, sure, they could put melanoma. Melanoma is going to look brown. It's going to be a brown patch. But basal cell is generally going to look more flatter, and squamous cells look more raised. All of these, even this one that's the same size as this one, you can see it looks like a ball. Whereas these ones here, they're like flat pancakes that are lying there.
Sorry, I'm confused which one is which there.
Sorry, this side is basal.
The left side is basal.
Left side.
cell.
Oh, can you not see my red marker?
It just moves a little quickly, but
Oh, okay, yeah.
it's
So
just a bit of a lag, but I can see it now.
Yes, the left side is, yes?
The basal cell is the one you have a red mark on it, right?
Yes,
And then
this side here.
Yeah, and underneath the skin, it will go deeper. It's deeper underneath the skin, right?
It's basal, yes, basal cells are generally deeper. So what you're seeing on the surface generally looks more flatter. But the squamous cells, they're beginning more closer to the surface. So that's why all of the growth that you see is actually more on the outside, and they look more elevated and raised. Does that make
Sure.
sense?
Yes, yes.
No problem. Any other questions? I see somebody typing.
Which one is a melonia in this picture?
There's no melanoma ones here. Melanoma is brown. It's a brown patch. It's
Okay,
literally just a brown patch. I'm going to talk more about melanoma on some of the other slides.
thank you.
Oh,
But
sorry. I
just
didn't
to
connect.
clarify, sorry, Priscilla, but for basal cell and squamous cell, those can lead to melanoma.
So any cell that's gone array can generally lead to, like, if you have any lump, benign lump inside of you, it can at some point mutate and become cancerous. So yes, they could.
Thank you.
But generally speaking, melanoma is the one that we consider the malignant cancer one, and there's an A, B, C, D, E feature for, I don't know if you ever did that, for knowing whether something is cancerous or not, and it has to do with what was A? So like the borders of it. So like if it's cancerous, the edges aren't going to be smooth. Like, see, these are all more, somebody wrote that inside there. They're all smooth and rounded for the most part. Cancerous ones, they generally look more irregular. And then they're bigger than the size of an eraser head. So bigger than 6 millimeters, generally speaking. And then the color is usually, like you said, it changes more towards like a dark brown color. But yes, anything can turn to cancerous. But when we see basal and squamous cell, the likelihood of somebody passing from that is very, very minute. I think when I was reading it, it was something like I think it was like 95, 97%. There's like, you'd have to have it there a really long time. And most people aren't going to leave that kind of growth on their face that long to get to that stage. But yes, it could. And I think it was basal cell, if I'm not mistaken, is the one that's more likely to, because it's deeper already inside the skin. But don't quote me on that one because I'm not 100% sure if I'm recalling whether it was basal cell or squamous cell. Actually, sorry, you know what? I'm confusing you with my other class. Okay, so I guess I don't have more on the melanoma ones. For the images of melanoma, because they all look the same, they were all literally just brown patches. So there was really nothing to show you to differentiate them because it's literally just a brown patch on the skin. Like, doesn't look raised, just it could be a freckle and it just turned brown and now the edges look irregular. Those are melanoma ones. All right, so compare and contrast with the rule and against the rule. So with the rule is generally you'll see, it's this side over here, you'll see it running from left to right. You'll see that touch band. And I always remember it because 180 is where the flatter K is on with the rule. And also because I always think of with the rule as water. Like you're just missing the vowels from it for water. And water flows usually horizontally from left to right. And then against rule, 90 degrees. So that's where we'll see the touch. Any questions on this one?
I find it helpful to associate against the rule with an hourglass shape.
Oh, that's a good one too. That's a good one too. Yeah. Thanks for sharing. All right, so now we're going to compare steep fitting and flat fitting lenses. So what are the characteristics we see on steep fitting lenses?
Heavy pooling in the center and edge lift.
Yes. Yes, touching on the side, pooling in the center. Yes, central pooling. Thank you for writing in the chat. And what is this one here showing that the other ones are not showing, which is also an indication of a steep fitting lens? I don't know if you could see I was on this one here. I'll leave my marker here, this one.
Bubble.
Yes, an air bubble. Yes, an air bubble being trapped is also an indication of a steep fitting lens because if the lens is flat, the air can travel through, right? Because it's bouncing all over the place. Air only gets trapped in the steep fitting lens. Yes, steep fitting, too tight, same thing. Yes. Thank you for writing in the chat, air bubble. I also see that too. And characteristics on the, so dimple veiling would be like the series of like little dots, like fine dots. Okay, flat fitting lens. What kind of characteristics do we see with those? Central touch, yep.
Peripheral pooling.
Beautiful. And what's happening in this picture here, the first one on the left? Why does this one look different?
It doesn't sitting well. I don't know what.
So in this picture here, what we have is it's a loose fitting lens, yes. So yes, the pooling will go down because the liquid will drain, but because this one has lid attachment, that's why it's all of the pooling is dropping to the bottom. So this is that's a loose fitting lens with the pooling towards the edge, towards the bottom. But this is a flat fitting lens as well.
So it's a combination of flat and steep then?
No. That is a flat fitting lens. Because if it was steep, when you see a steep lens, you have very little movement, right?
Right.
Whereas a loose fitting lens, that's the lens that'll be bouncing all over the place. And so it's more likely to get more lid attachment. With the steep fitting lens, because it has such little movement, lid attachment is nil because it barely moves. But good questions. Thank you for your participation.
Oh, thank you.
All right, so now we're going to go over some images. So what I'm going to do is I'm going to show the image, and you guys are going to get the answer. I'm not going to tell you what it is until you get it. This one.
Sty.
Yes. It might be easier if you come on the mic.
Keratoconus.
Yes, good job.
Corneal ulcer.
Yes, beautiful.
GPC.
GPC.
Good job.
Blepharitis.
Yes, good job.
Cloudy?
Cataract.
Corneal cloudy? No. Or
Cataract.
cataract?
Yeah, you're both right, but the answer would be cataract. Yeah, it is corneal clouding, but the technical term would be cataract. Good job.
Keratoconus, but was it Munson sign?
Yes, if they show it like this, then the answer is Munson sign.
The answer is what? Sorry?
Is Munson sign because they're actually showing you Munson sign.
Yeah.
Yeah, the V, yes. But you're right, the cause would be keratoconus.
Squamous cell carcinoma.
Good job.
Foreign body.
It's not funny. They have a nail in their eye.
Keratoplasty.
Oh, keratoplasty. Yes, I see somebody wrote it. Good job.
Displacement of RGP.
Yes. Displaced lens. Yes. Or decentered lens. Yes, that's good too.
Melanoma.
Basal cell carcinoma.
Basal cell. Good job. I see it in the chat too. Good job.
Pterygium.
Good job. Good job. I see it in the chat too.
That's keratoplasty again, isn't it?
Good job.
Pangecula.
Good job.
Ugh.
Mm.
Always remember razor flat.
Squamous cell.
Yes.
Is it melanoma? Melanoma?
No.
No, melanoma is always going to be it looks like a brown freckle that's with irregular. So usually you don't, I don't think I've ever seen those in a pathology slide. I usually see basal and even though we learn about it, but I mean, it literally looks like a brown freckle with irregular, not smooth edges. Yes, squamous is this one.
Neovascularization?
No.
Upper lid attachment.
So you guys see the contact lens in the picture, right?
Hmm.
Do you see it?
No.
Mhm. Yep.
Oh, you don't see it.
Is it
There's a
broken?
contact lens in the picture. Yes. Somebody's saying it in the bot said it's the bottom is cut. What does the bottom cut mean? What kind of a lens is that?
Scleral? No.
When we cut the bottom off, what do we call that? Truncated. Yes. Truncated lens.
Truncated.
Oh.
And you are right. It is for prism. Or to stabilize a lens. Could be for astigmatism too.
Podolium.
No.
Which one is this one? Oh, somebody wrote Chalazion.
Sty.
It's
Yeah,
like
it's a sty. Yeah, you can kind of see right here. I don't know if you can see my red marker. There's almost like some like dippling there. It looks infected. And like you can see that it kind of reaches over to here and here. If it was a chalazion, it would look more ball-like. It wouldn't be so pointed here in the center. A little bit more rounded. Yes, hyphema. Oh my God, somebody wrote that real quick.
With the rule.
Yes, good job.
with the
What is
Sorry, yes?
astigmatism
so
with the
what
rule.
was that one? What was that one?
This one?
Yeah. Yes, yes.
With the rule.
Oh, okay. Yeah. Thank you.
You're welcome, no problem. We're gonna go back, circle back through this again.
Perfect. Thanks.
Oh yes, Sty, sorry, I didn't see somebody wrote it. Good job.
Corneal ulcer. Corneal clouding.
So that's actually a lens that's on their eye.
But what about the left side? That's all cloudy. Or is that just their iris?
RGP.
So
Right.
if there is a lens in the picture, then your answer will always relate to because if it was just an issue with the eye, there would not be a lens in the picture. So if you get an image and there is a lens in there, then whatever your answer is relates to it. I do know what you're saying over here. I think that's just bad camera, to be very honest. But if there's a lens in the picture, it always has to relate to the lens. It's not bubbles, but you're going in the right direction. You see what it is in the image. But those are
Lipid?
not bubbles.
Is it
Protein
lipid?
deposits.
Lipid
Nope,
deposit.
it's not deposits.
Scratch lens. Or is it a right lens because it's has a hole in it?
You're right, it is
It's
a hole.
It's
What
a
do we call it?
PMMA lens.
There's-
Oh, Warpage. Warpage
There's
oxidative
three
RGP.
holes in it. What is that?
Warpage RGP? I don't know.
No, it's for the tear exchange to allow more oxygen to get through. Forget what it's called.
Starts with an F. Nobody has any guesses? Do you want me to tell you the answer? Okay, I'll tell you the answer. Fenestration. Those are three dots for fenestration.
Mhm.
All right, next one. Yes, Arcus canelis. Good job. So basal, base, flat. Yes, squamous. Good. This one is squamous. Good job. This one? With the rule. Great job. Good job. Basal was the answer for that one. For those of you who don't see in the chat. Steep
Yeah,
fitting
yeah,
lens.
I-
Good job.
Sorry, I
And
don't see
also
the.
note air bubble. Because
Air bubble.
sometimes the answer is air bubble. If you've seen it, steep lens with air bubble, I would say that. Sorry, somebody was saying something?
Yeah, I just don't see the chat. So if you don't mind, if you could like repeat whatever, like.
Yes. Sorry.
Yeah.
Do you want me to go back?
No, that should be fine from now on, please.
Okay.
Thank you.
No problem.
Thank you.
All right. So steep fitting lens with bubble. Next one.
Sty.
Good job, Sty. Yep. Corneal ulcer. Great job.
That image, wasn't that under the abrasion slide? I thought I might have
This
seen
one?
that. Yeah, that one. I
Mm-mm.
know it's an
You can give a
ulcer.
different one.
Sorry.
That's okay.
Sorry, can you repeat that one, please?
Corneal ulcer.
Corneal ulcer. Okay. Is that
Yeah.
possible? I don't see the chat. So is that possible to when you call it your name? I mean yourself.
Yeah, so I thought I said it out. Sorry, if I don't say it out, I thought I said it out. So maybe I'm saying it in my head.
Yeah.
Then just call me out on it. I apologize. I thought I said it
No,
out.
no problem.
Can you call me out? And you got this one already. You said sty. Good job. Radio K, beautiful. Yes, entropion. Good job. It's entering the eye.
Neovascularization.
Yes, Panis is the more technical one. Yes, but I'm sure they would probably give it to you if you said neurovascularization. But this one is Panis.
Pterygium.
Oh, sorry, pterygium. Sorry, I didn't see you wrote it. Good job.
Aphakia.
Cataract.
Cataract.
You're on the right path. You're on the right path. Cataract. No, you are.
GPC.
Yes, good job. GPC.
GPC. Yeah.
Good job.
Yeah.
Yes, dendritic ulcer. Good job. Yes, ptosis. Good job.
So what was it? Sorry.
Ptosis.
Ptosis. Okay.
The same lid attachment as you say, loose fit.
Loose fitting lens. Good job. Flat lens. Good. Hyphema. Yes. You guys did pretty good. Pinguecula. Good job.
Yeah.
You guys are ready. Yes, Chalazen. Good job, Katie.
That one was Chalazen.
Yes, this one is Chalazen. I know it's tricky because right here it almost looks like it's infected. No, because it got me too, Katie.
No, the previous one.
But
The
it's
previous
actually
one?
because they had fluorescein, and that's actually fluorescein that you're seeing there. And you can
I
see a
think
little bit over here too.
the previous one.
No, I'm talking about this one because she put that it was a sty. But this one actually tripped me up too because when I first looked at it, I thought, "Oh, is that an infection there?" But it's actually a chalazion. That's actually what do you call it? Fluorescein on her lids. Yes. Foreign body. Good job. You type super fast, Katie. Like OMG. Yeah, with a rust stain around it. Yes, ectropion. Good job. Good job. Good job.
Herpes? No? Yeah, herpes.
Yep, dendritic ulcer. Good job.
Sorry, what was it? Sorry, what
Dendritic
was
ulcer. This one?
dendritic?
This
Yes.
dendritic ulcer.
Dendritic
See the branch line?
ulcer. Oh, right. Dendritic ulcer. Okay.
Arcusinus. Good job. Ulcer, corneal ulcer. Great job. Basal. Great job. Chalazion. Great job. GPC. Great job.
BPC?
GPC. Giant papillary conjunctivitis.
Yeah, sure. Thanks.
Ectropion. Good job. This is the one I think you were thinking of when you asked me the other one that had the fluorescein on it. Yeah, corneal abrasion. Yeah. It's a little smaller on that screen, so a little harder to see. Pterygium, good job. Good job. Arcocinilis. Hyphema, great job. You guys are good.
Teacher, is a little
see?
too fast. Teacher,
Oh,
can you,
okay, sorry. Let me go back. I'm going to go through these again.
yeah, a little bit
Okay, I'll go
slow,
back. Let me
please.
go back a few. Let me go back a few.
Thank you.
So this one was pterygium.
Yeah.
Arcocinilis.
Right. Thank you.
Hyphema. You can see the blood down here.
Mm-hmm. Yeah.
And GPC.
Yeah. Thank you.
You're welcome. I apologize. I'll go slower.
No.
Thank you for calling me out. I'm sure you're not the only one. Yes, cataract. Squamous, great job. Steep fitting lens, good job. Foreign body, great job. Chalazion, great job. Dendritic ulcer, great job. Oh, subconjunctival hemorrhage, great job. GPC, great job. Ectropion, great job. Sty, great job.
Sty? Sorry, what was it?
Yes, that was sty. Yes, that was sty. Sorry, I'll go back. That one was sty.
How do you spell it, teacher?
STYE.
Thank you.
You're welcome.
Okay.
Yep, corneal abrasion. Great job. Pterygium. Great work. Entropion. Great job. Yes, trogaricus. Yep. Pterygium. Great job. Sty. Great job. Steep fitting lens. Great job. GPC. Great job. Entropion. Great job.
Recrectum?
Sorry?
Recrectomy? This one.
I can't actually hear. This one is keratoplasty. I can't hear the
Oh.
actual the word that you're saying.
No, that's one because I was wrong. Yeah.
Oh, okay.
Yeah. What is the
That's
name of this one?
keratoplasty.
Keratoplasty. Yes. Thank you.
Yes. So you can see the bandages. I mean the stitches still there,
Right. Right.
and they are nowhere near the pupil. Yes, you can say corneal graft as well
Right.
for the previous one. Somebody wrote it in the chat. Yes, pinguecula, great job.
Good.
Corneal abrasion, great job. Entropion, great job. Against the rule, great job. Pinguecula, yes. You gotta look closer. Yeah, right here. Yes, it's really irritated. You are sure. You are right. You're not wrong. But the reason why I put those ones in there is because I want you to look beyond. Radio K, great job. Flat fitting lens, great job.
What was that one, teacher?
Flat fitting lens?
Oh, flat. Okay.
Flat, yeah.
Okay. Yeah.
With the rule, great job. Ectropion, great job. Yes, the little R is right lens on that previous slide. I saw that in the chat, Katie. Good job. Against
it-
rule? Sorry?
No, no,
Sorry?
no. Yeah, I'm
Oh,
fine.
okay. Okay. Against the rule is right for this one. GPC, great job. Hyphema, great job. All right, good. You made it through. All right, so do you want to go through it one more time?
Yes.
Okay. Go back.
Thank you.
What's this one? We went quiet all of a sudden.
Side.
Sky. Good job.
Keratoconus.
Keratoconus, great job. Corneal ulcer, great job.
GPC.
GPC, great job. Blepharitis, great job.
What was it, teacher?
Blepharitis.
Blepharitis.
Blepharitis, yes.
Can I see one more time, teacher? Please.
Sure, yeah. Let me go back.
So it called blepharitis.
Blepharitis.
Oh, okay.
This is a close-up on the lids over here.
Yes.
Okay. And I see you guys already wrote the answer for this one, which was cataract. Great job. Munson sign, great job.
Mountain sign.
Munson sign.
Thank you.
You're welcome. So basal is flat and squamous is raised. Yeah, squamous. Great job.
Korean body.
Foreign body, great job. Keratoplasty, great job. Yeah, decentered or dislocated lens, great job. Basal, good job. Pterygium, great job. So remember the radio K ones, they went right over into the pupil. So this one is still around the edges. You can actually see the stitching on it. So this one is actually keratoplasty. Yeah, corneal graft. That, you don't have to be sorry. That's what this is about. So you make your mistakes here, not there. Pinguecula, great job. Squamous cell carcinoma, great job.
Trunk.
Truncated lens, great job.
This is for prism, you said?
It's to stabilize the lens. So it can be used for a prism, or if you have a lot of astigmatism, to stabilize the lens.
Oh,
Prevents the lens from turning because it's flat on the bottom.
mhm.
Sty, great job.
Aphonia?
Sorry, I didn't hear you. Yeah, hyphema.
Hyphoma?
Yes, great job. With the rule, great job. Sty, great job.
Fenestration?
Great job. Fenestration. Arcusinus, great job. Right, raise, squamous. With the rule, going from on the 180, good job. Basal cell, great job. Yeah, there's a bubble, so what does that indicate? Yes, steep fitting lens with air bubble, great job.
What is it? Sorry, what was teacher?
Steep fitting lens with an air bubble.
Okay, thank you.
You're welcome. They may still give it to you with just steep fitting lens, but if you see an air bubble, I would say it.
Sure.
Because I don't know exactly how they're going to mark it.
Mhm.
Sty, great job. Yep, corneal ulcer, great job.
Sty.
Sty, great job. Sorry, I didn't see it there. Sorry.
Yeah.
Radial K, yep, you can see those lines over into the pupil area.
So what was that, teacher?
Radial K,
Radio, okay, yeah, thank
yes.
you. Thank you.
Entropion, great job. Canis, great job. Pterygium, great job. Cataract, great job. GPC, great job. Yep, dendritic ulcer, great job. Ptosis, great job. Flat fitting lens, good.
What was that, teacher?
Flat fitting lens, let me go
Oh,
back.
yeah, thank you.
Flat fitting lens.
Right, thank.
Hyphema, great job. Pinguecula, great job. Chalazion, great job. It's a Chalazion. You got it this time, right, Katie? Didn't trick you this time. This is the one that's tricky because the dye looks like it almost makes it look like there's some form of infection there, but that's actually fluorescein staining, not white pus.
Foreign body?
Great job. Ectropion, great job. Dendritic ulcer, great job. I don't think they're going to be that particular, but I'm not the one I've never marked in NACOR. I've only marked in the comps at Seneca. We were never that, like, as long as you can really tell. And people know that you're nervous, so I doubt that they would be that particular on spelling. That would be mean. I don't think so. Arcus that's right. Oopsie, sorry, I went through two. Ulcer, great job. Basal cell carcinoma, great job. You know, this one I always have to think back to because, but it's actually a Chalazion. It's just a discoloration there because his skin is stretched, but it's actually a Chalazion, yes. There's no indication of any infection there. GPC, great job. Entropion, great job. It's okay. Corneal abrasion, great job.
Sorry, teacher, what was that one?
Corneal abrasion.
Oh, thank you.
You're welcome. So you can see that there was something there and they were blinking back and forth.
Mm-hmm.
It was scratching up the whole bottom area.
Yep.
Pterygium. Yeah, wedge-like growth or V-like growth, as somebody said earlier. Arcus, great job. Hyphema, great job. sorry, GPC, great job. Cataract, great job. Squamous cell, great job. Deep fitting lens, great job. Did I skip something? No.
Foreign body.
Foreign body, great job. Sorry, Iris, I didn't see you wrote it. And you, been. Chalazion, good job. Dendritic ulcer, great job. Subconjunctival hemorrhage, great job. GPC, great job. Ectropion, sorry, yes, great job. Sty, great job. Corneal abrasion, great job.
Pterygium.
Pterygium, great job. Entropion, great job. Pterygium, great job. Sty, great job. Steep fitting lens, great job. GPC, great job. Entropion, great job. Keratoplasty, great job. Pinguecula, great job. Corneal abrasion, great job. Oh, did I just go back? Entropium, great job. Against the rule, great job. Pinguecula, great job. Radial K, great job. Flat fitting lens, great job. It's going from left to right with the rule, great job.
Ectropion.
Good job, ectropion. Oh, sorry, yeah.
Against the rule.
Against the rule, great job. GPC, great job. IFEMA, great job. All right. Now on to contact lens referral. Everybody's good, right? I'll post it for you guys. So if you want to go through it again later, you can.
Thank you.
No problem. All right, so this patient comes in. So first of all, what is it?
Sorry.
Okay. And so how would you recommend for this person to treat this? This is a child. Yeah? How many times a day are we going to do these compressions?
4 times.
Yes. 4 to 5 times. Good.
4 times compression per day.
Sorry?
Per day? 4 times per day.
Yeah,
Okay.
45 times per day. But I guess somebody wrote 3 to 4. It's pretty small. You could probably get away with 3 to 4 too, because it's pretty small. All right, this one here. What is it? Yes, it's a Stein. It looks very infected. So what would you recommend to this patient? Okay, I've never, okay. Polysporin, all right. Yeah, it's infected, so I would have a doctor write a prescription for them for infection. But I don't know, I've never tried polysporin. That's the first for me. So, but yeah, that's a good one.
But polysporin would be for open, like ulcer, open. But this is like underneath the skin. So probably antibiotic or something, I assume.
Yeah, I think polysporin actually does have some antibiotics in it. But generally, if this was an answer on an exam, I would say I would say I would refer this patient because this looks very infected and it's not just one spot. Yeah, I would refer to a doctor. So if this patient wanted to be fit for contact lenses, would you fit them?
No.
Great job. So this patient is coming in and they want to purchase glasses.
After cataract surgery.
Yes, I would send them to the doctor. Yes, I would send them to the doctor.
Right.
Yes, you have to refer to the doctor so they can have that dealt with. But since it's actually like an actual physical object in their eye, because if you just send them to the time to book appointment with their doctor, you also have to consider the urgency of some things too, right? They actually have an object inside their eye, yeah. So it's either I would send them to the emergency so that they could get it removed.
But we don't do contact lens, right? While
No, we would not do contact lenses. No.
Yeah, sure.
So would you fit this patient with contact lenses? I think we already discussed this one partially. They come in wanting contact lenses.
This is what they call for this one.
This one is, can somebody say which one this was? I don't want to give the answer away. Entropion, yes. So unless you're using it for a bandage, I would not recommend I wouldn't say fit that person with the contact lenses. Why? Because the lashes on the eye are meant to protect, which it's not protecting anymore. It's allowing dirt and debris inside, right? But if you are putting it in there to protect their eye, then that's different. But just for vision, I would tell them to wear glasses.
So just bandage contact lens, you mean?
Yes.
Okay, thank you.
But the bandage lens can have a prescription in it, but I'm saying if it's for that purpose.
Right, right.
Because then you are not introducing a foreign object that can possibly complicate things, right? You're doing it to prevent something that's already happening, so you're helping their eye.
So bandage contact lens, which has a prescription in it.
So I'm saying that if you were going to do a bandage lens, you could do one that had a prescription. But what I'm saying is that the purpose of it would be for that, not just to give somebody correction.
Yeah, for preventing from more damage.
To protect their eye, yes.
Got it. Yeah, thank you.
Yes, you're welcome. Only from this side they will ask. I'm not sure what that means. So they'll give you. So it's only going to be. It's actually going to be a multiple choice question. So you're not actually going to have to answer. You're just going to choose out of the better of the answers that are there. You don't actually have to write anything. It's multiple choice. So they'll give you an image, ask you a question. If a corneal abrasion is from trichitis, a bandage, then plano or RX will protect you from front. Yes, that's what we're talking about. Yes. Katie, I agree with you. She's saying if corneal abrasion is from trichitis, a bandage, then plano or RX will protect them from further abrasion. Yes, that's what we were discussing. All right, so this patient wants to get contact lenses. Would you fit them?
No.
And why wouldn't we fit them?
That's Trojan, right?
Pterygium, yep.
Trojan.
Yep.
And
Refer to the doctor. I see it's written in the, because what is the concern right here?
contact underneath the contact lens has to be clear, but this is not clear because as we see is on the iris and up
Yeah.
close to pupil. So
Yes, and somebody wrote in the chat the pupil. It's starting to invade the pupil, which is gonna forget about contact lenses. Now we just got to protect your vision, right? Because
exactly.
once something starts invading the pupil, it's gonna start to block your vision because the light has to pass through your pupil in order for you to see, right?
Yeah.
Yes, if it's past the limbus, we're not fitting with contact lenses. Yeah. And actually, like, because if you're fitting a scleral lens, there's like a 1 millimeter, like 1 to 2 like barrier on the limbus area. So you have to imagine where the lens is, and if it's going to be touching the lens, then no. They want contact lenses. Would you fit them? Looking at this one, it's not a depends. This person came in. Would you fit them?
I don't.
I see yeses. Location, yes. Because there is enough of a border there. So if you justify that and you say that, you actually have to put all of that there. Like it's past the lid margin, so I would, right? You'd have to actually say that.
So is
Not lid. Why did I say lid? I'm sorry. I need food. It's it will not interact with the contact lens. It's not near the limbus area. Thank you, Katie. Would do dailies. Okay.
What this one called? What this one called? Sorry.
This is a pinguecula.
Singular.
Ping, P-I-N.
Oh, pinnacular.
Yeah.
Yeah. Thank you.
Sorry. Would you fit this person with contact lenses? So tell me why you would fit this person with contact lenses. Your reasoning. But when you're putting the lens in your eye, what do you have to touch?
Upper and lower lid.
Yeah. So every time when they go, they're going to be touching that. And then they may be touching it into that just, yes, infection. And that already looks infected. Like they need to get that taken care of. Because that isn't even, that's past the 6 mark and it's turning brown. Awful. Yeah. It's like a sore on a scab. Oh, sorry. So this person wants to get contact lenses. Okay, so I see a yes and I see a no. So in this present moment, I agree with Katie, no. But a yes, that I will fit you once you've done your compressions and it's gone away. It's a very small one, right? So if you're asking me would I fit them, I would say no. Yes, once the chelation is gone. So we're going to send them away. What would you do? So, this is a child. This is a child. So 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 this is What are you going to recommend? They're coming in to get glasses.
I think we could give him glasses, but not contact lenses.
Okay. What about referral or no referral?
Referral, definitely.
Yeah. Because this is very significant now. So the compressions at this point it's too far gone, right? So and because they're a child also, we want to
Yeah.
make sure that they see a doctor, right? Because this is getting pretty big.
Do we usually send it to optometrists or ophthalmologists?
So we don't refer in order to send somebody to an ophthalmologist, they'd have to have a referral. They could see an optometrist. But
Oh,
I mean, like this person here could essentially go to their family doctor.
right. Yeah.
And that'd probably be quicker, and the parents would be able to take them faster, and it's not going to cost them because it's covered too as well.
Yeah.
Does he has Marcus? Marcus, what's Marcus? Oh, this picture? No, it's not Arcus actually. So actually what it is, and I don't know if you can see in my eyes too. Like on some brown people, you'll just see like on the limbus area where you can see the pigmented color behind. It's like almost like just like where the white and the God, I can't find my words tonight. I'm so sorry. Iris, that's what it's called. It's called an iris. Where the iris and the barbell conjunctiva are like connecting, like it's kind of like overlapping. All right. Great job. So first of all, would you fit this person with contact lenses? Why wouldn't you fit them? Yep, dry eyes. But this one actually looks like they're tearing excessively because it. But what are you gonna? But also too, if you look right here, I don't know if you can see my red marker. This looks like it's infected right here. So what are we gonna recommend then? Yeah, they need to see a doctor because this could go really, really bad. So this person is coming in to reorder their contact lenses. What are you going to recommend to them? Remove from lens. Yes, they need to discontinue wearing their lenses. And then come back. Great job. Yeah, and then once it's dealt with, then they can come back. Great job. Yes, clean on teaching. So this one, are you just going to tell them to discontinue their lenses? Yeah, we're going to need to refer on this one because they might need some medication to help this move along. Like just this is pretty far gone. They've been dealing with this for a while now. Sorry, did I skip slides? Okay, no, I didn't. No contact lenses, yes. Anything else you're going to say to them?
Oh, no.
Yeah, they need to referral. Are you going to tell them to, book an appointment at their nearest time, or are you going to, what are you going to say? They need to go to the emergency. Absolutely. Because this is going right into their cornea. This gets infected, that's their vision that's gone, right? Because we see 2/3 of our vision comes from our cornea, right? Absolutely leads to infection. Great job. So are you going to fit with contact lenses and are you going to refer?
I think we could do contact lens with this one, and with referral too.
Okay, so this one, I feel like this is like a personal preference one because literally it doesn't really affect the lens. However, if you want to make sure that it's clear, I wouldn't fit this person. And the reason why I wouldn't is because I want to make sure that it's clear, and people tend not to come back for follow-ups when you give them lenses. They're like gone. So I wouldn't fit them with it. Are we referring or are we not referring?
I think it's gonna go away by time.
Yeah, no referral. Great job.
Yeah.
So you're looking at the lens, you fit this person. What are you gonna do? So first of all, what kind of fit is this?
Flat?
It's a C-fitting lens. Yeah, I see order a flatter lens. And so what does order a flatter lens look like? What are the items that you would change? So are we going to increase or decrease the diameter? Are we going to increase or decrease the base curve? Reduce edge lift. Yeah, so we're going to decrease. Decrease the diameter. When you decrease the diameter, it loosens the lens. Great job. What about this one? Or order a flatter base curve, yes. Yep, so you can increase, it's a flat fitting lens, right? So we can increase the diameter, order a flatter base curve, tighten the peripheral curve, depending on what you're doing with the lenses. Great job. All right, signs, symptoms, and treatments. Okay, so what is the cause of this? First of all, what is this? Yep, UV sun dust. Yes, it's a pterygium. Great job. Sun exposure. Great job. Yep, smoke too. Yep. What is a symptom for this one? What would your patient be complaining of? Itchy? Yeah. Burning, their eyes might be irritated. Sand-like feeling in their eye is a common one. Great job. Yes, poor vision. Yes, they would complain of poor vision because and on their lenses, it would create like they'd put the lens in to be able to see clear, but then they'd be like, oh, my lenses are getting dirty quickly. But it's not. It's from the GPC making the lenses dirty and blurry. What is the cause of this?
To exchange the they do fenestration to exchange the I forgot. Well, I forgot.
So it's a GPC in there. So the oxygen is good. It has to do with what kind of fit it is. Yes. Tight fitting lens. So those holes allow the fluid that is trapped in the center to come out. Yeah. Okay, yes. I see what you're saying. Yes, to allow oxygen to the center ends. Yes, sorry. Okay, yes, I'm awake. Yes, you're right. So what's the treatment for this? Careful, read the question. Not cause, treatment. IOL, surgery. Good job. What is the cause of this? So is this a chalazion or a sty? Yeah, it's
Chalazion?
meibomian glands. Yeah, it's a chalazion. So is a chalazion an infection or a blockage?
Blockage.
Yes. And so what is blocked?
Meibomian gland?
Yes, the meibomian glands are blocked. So that's the cause of it. It's a blockage in the meibomian glands. And it may not necessarily have anything to do with hygiene. It's just sometimes things get blocked up. But it could be.
Right.
What is a symptom that this patient would experience? What would they be complaining to you about? Yes, blurry vision. Specifically, what is their greatest issue? Yeah, they may see halos. Nighttime driving, yes. The biggest thing people with cataracts complain about. So what does the lens do inside of your eye? Poor reading, yes. The lens is accommodating. And so once the lens is becoming cloudy, it's not accommodating. So yes, your distance is affected, but your reading is affected more because the elasticity is gone and they're having more and more difficulty reading. And no matter how much magnification they put and light they put, they can't see. But yes, all those other things are also true that you said. Decreased vision, nighttime issues, blurry vision, also in the distance. Those are all true. Yes, but one of the greatest symptoms that they always complain about is their reading. What is the cause of this? I think we already discussed this a little bit earlier. You guys beat me to it. It's like to see through the fog. Oh, it's like looking through fog, yes. So it can help with prism to stabilize it. Yes, it's to stabilize the lens. Yes, that's what the so it can also be for a lot of astigmatism, right? So if you've got a toric lens, a specialty toric lens, it's got a lot of astigmatism. There's less tolerance, right, on the lenses. So if you've got like a 3-cylinder, or a 350 cylinder, 4-cylinder, or even 5 cylinders I've fit before, you want to stabilize that lens, right? Because the tolerance of swing on the lens, 1 to 2 degrees, right? And then they can't see. So the truncation helps stabilizes the lens, so it's to stabilize. How would we treat this? Actually, kind of talked about this already. Steepen the lens, yes. What is the cause of this? Okay, yeah, it could be corneal thinning, keratoconus, yes. So there's some issue with their cornea, and we're transplanting it. Great job. What is a treatment for this? And there are multiple, so you can pick any. So yeah, you can say ortho K, but you also have to kind of be careful, right? Because of the thinning of the cornea. So I think that would more depend on the condition of the cornea. Wouldn't necessarily go straight to that one. Scleral lens is often yes. Contact lenses, but contact lenses in general, yes. Graft, yes. Great job. I think you guys already touched on the symptoms of this one already. You can actually see inside this patient that they've got excess tearing. And that's their eyes trying to compensate for the constant exposure. Treatment for this one. I think you guys already touched on this one already too.
Sorry?
Yeah. Warm, hot compressions, 3 to 4 times a day. For this small one, I don't necessarily know that you need to refer, but you could refer, seeing that you do see a lot of the pus there. I mean, you can never lose by referring. What is the cause of this? Yeah, overwearing of contact lenses, dirty lenses. Yep, sleeping with contact lenses will do that too. What is a symptom of this? Yeah, bloody vision. Not even blurry. Yeah, I like that one. Yeah, and pain. Right? What is the treatment for this one? I touched on this one already too. Yeah, we need to flatten the fit. Sorry about that. Yep, so you can decrease the diameter, yeah. And flatten the base curve. Great job. And I think that's it. Let me just make sure. Yep, we have come to the
Teacher,
end.
sorry. Teacher, this one is the steep fit?
Yeah, this is a steep fit. So
Okay.
the treatment for it would be to flatten the lenses.
Okay, thank you.
Is there anything in particular that anybody wanted to go over? Or? But anybody that wants to go, you're free to go. That's the end of my slides. I hope you found it helpful.
It was very helpful.
So like I said, I'll post it, but please don't spread it around because I'll get in trouble because I don't have my citations on it. I didn't give credit for, I have the citations, but I didn't post them on the actual, I didn't get a chance to post them on the actual, I just have them in my notes on my slides. Should we look at other pathologies, just the most common ones in NACOR? Like which one? I tried to put pretty much everything that I could think that could possibly be there. But like, yeah, I'll post a slide for you. You can download it. Okay, no problem. Oh, no. I don't think there'll be a microcyst there. Keratitis, yes, that could be there. Yeah. Yeah, mucin balls could be there. That's a good one. Infiltrates, yes, that one could be there. Yeah, so somebody actually wrote it in the chat. Pannus is between 10 and 2. Generally, it's under the upper lid area that you'll see pannus, but it can actually go all the way around. So you're looking at a series of blood vessels that is surrounding the invading the limbus area all the way around. Then we'll call that one pannus. But to be honest, if you put neurovascularization, I really don't think that they would mark you very harshly, but you may have a deduction of some marks. I would put neurovascularization if I just saw it in one area. But if I saw a series going across the top, I would label it pannus. Or all the way around the eye, I would call that pannus. most of the slides that I've seen where they're showing pannus, it's usually, I've seen it on like either just the top portion or all the way around the eye. And then for the ones that were near vascularization, it was usually like at 3 or 6, like those spots over there. Usually when I've seen those ones, but not to say that those are the only ways, because I mean, things can change. But generally speaking, has a film behind, and it has a, I don't know what you mean by film behind it. Corneal erosion? I don't know that I've actually seen that one as a pathology slide. But I mean, know it. I think the likelihood of it, I think they generally try to put the more common ones, but could you tell us which ones are most common? The ones that I put here are very common. Those are very, 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 very common ones. And I actually pulled some of the ones that we used to use for our comprehensive exams here and include them in the side of the slide. But that being said, and the ones that that infiltrate one, and what other one did somebody else say? I've seen those ones. And mucin balls, I've seen, and keratitis, I've seen those. Go down, I don't know what you're writing. Yes, nevus, yeah. Or iridectomy, or another one I've seen. Oh gosh, it's not coming to me right now. The one looks like a keyhole. Oh God, my brain is farting. I'm so sorry. I should stop recording this. All right. Okay, so this patient's coming in to purchase glasses. What would you suggest? What do you notice about this patient? Yeah, they're albino. Good job. And what are some common issues with people who are albino? Yeah, sunglasses, definitely.
Photophobia.
Mm-hmm. What other issues can no eyelashes? I think you mean like there's no color in them, so it looks like there's none. There's no pigmentation in them. Yeah. All right, so you said sunglasses. Anything else you might suggest for? Oh yes, they have high RXs. Good job.
Transition.
Yep, transition is also another option. You could also give blue blocking to relax their eyes. Okay, yeah, I think I'm. This patient's prescription has prism in it. What condition might they have? Yep, strabismus. Yep. All right. So this patient comes in. Oh my gosh, sorry. Patient comes in for contact lenses and says they recently scratched their eye and it's been hurting them. They feel photophobic for a few days now. They want to replace their contact lenses. This is a quick glance of their eye. Yeah, so the picture is showing Munson sign. You are right, they do have keratoconus. What kind of keratoconus is this?
Monson.
Globus, good. So first of all, there's a couple parts to this. Why do you think their eye is hurting? It could be pressure, but oftentimes people with glaucoma, they don't complain because it's pretty, some do, but reading the case scenario over. Read the case scenario. Yes. And so why would the scratch be hurting them? So, okay, yeah, so the scratch is hurting them. Okay, so now they've said that they're feeling photophobic now. What could be causing the photophobia? Sorry, I look awful. I'm coming off camera. Yes, but yes, it could be thinning of the cornea. Yes, because they do have keratoconus. What else could it be? Yes. Yes, the scratch could be getting infected and turning into an ulcer and creating photophobia. Great job. So you already got the diagnosis. Okay, so would you give this patient contact lenses? Why or why not? No. And why? Yeah, so it could be either, like you said, right? So they're seeing the photophobia, and so we don't know what the cause of that is, so we have to investigate that further. And then, moreover, if you are gonna, and somebody also points out the fact that their cornea could be thinning, and so we want to get all those things checked first before we, yes, do anything. And so you already talked about the next steps. All right. So this patient came in. Okay, so this patient came in, and they want to buy glasses. Do you have any concerns on filling this prescription? Why? Okay, yes, the prescription is old. Yeah. So, Katie, you talked about vertical imbalance. I think you need to kind of expand a little bit more on that one. Yeah. And so what does the diabetes say? Yeah, anesometropia. So what concerns do we have with the actual, okay, so with the actual prescription, what concerns do we have? So somebody talked about the date. So what concerns are attached to the vertical imbalance, potential vertical imbalance with the difference in the prescription or the anesometropia? So if it's an old prescription, they're probably already wearing something similar to this. But what potential issues could be arising? The prescription is 10 years old, so the ad may not be missing. They might not have had it. So yeah, double vision is an issue. Diplopia is an issue. But what is the concern that we have as an optician? All of those things are true, but how does that show up for this patient? What are we concerned about happening? Yeah, they're diabetic, prescription change often, so that's a reason to tell them they need to get an eye exam. So give me the connections with the medicine, what you mean by that. Overcorrecting? Can you expand on what you mean by overcorrecting? Dry eyes? Okay, so where are we getting the dry eyes from? Are you saying that due to age? So first we can check their vision, yeah, to see, but to see if they're having difficulty seeing up close. But if they're and why they're coming in to get glasses. But what other issues can arise? Overcorrecting vision is never good. How will we be overcorrecting? Oh, you mean like their prescription has changed? Is that what you mean by that, Katie? Maybe they were prescribed monovision? No, this is his distance pair of glasses, and he actually has a distance pair of glasses, but they broke. But they've been broken for a while. He just didn't bother to come and get them fixed. And now he wants to refill it. So what exactly are we? Okay, so what happens visually? Let me reel you guys all back in. So what happens visually when one eye can see clear and the other eye cannot? Yeah, one will be thick, the other one will not. No, so one eye sees clear and the other one does not. What happens? Or what can happen? Not a cataract. So looking at his prescription, right? So in the right eye, we've got -50, 125, pretty mild prescription. Left eye, very significant prescription, you would agree, right? So essentially, if you think about it, if this prescription were accurate, right, this person could potentially walk around and look with their right eye alone. They would be able to see clear. Essentially, pretty much, right? But in their left eye, they would not see clear. So let's just say, so we're going back to the whole point of this prescription is now 10 years old. Somebody pointed out the fact that this person is diabetic, so they're prone to prescription changes. What concern do we also have for this patient's visions? Amblyopia, yes, amblyopia. Because if your brain is only perceiving information from predominantly one eye, it tunes out the other eye. And if the other eye is getting worse and worse and we're not correcting it, which this person may not notice, right? Because the other eye could be compensating for it, then we're going to have a problem. And they may see slightly better out of that left eye with the glasses on opposed to without. You also point out the diabetic, right? But there's something protect the right eye with good material. Yes, we're going to protect the eyes. But it's not that they're amblyopia. It's that they can become amblyopia. This could be their true prescription. They could see clear. Like I have seen patients like this where they see perfectly clear with glass like this, 20/20 vision in both eyes. This is their prescription. But the reason why I did get there was because, yes, one eye wasn't seeing well and it wasn't caught soon enough, right? And then now they're in this situation here. But yeah, so we want to tell them to go get an eye exam to prevent them from becoming amblyopia, because this patient, if they can see clearly with both eyes right now, is not amblyopia, right? Because you can have prescriptions like this, and then there are concerns, are they going to be able to fuse the images because they're going to be totally different sizes? Left eye is going to be significantly smaller of an image than the right eye because of the high minus, right? But if they're already wearing glasses like this for a significant amount of time, that means that they've already learned to fuse that. So we're not really that concerned about that unless it is a significant change from a previous prescription. So if they came in now and the prescription was, let's say, -8 in the left eye, then maybe we might be concerned that maybe they're not going to be able to fuse it because this is like a 3 diopter change. But if a prescription is similar and they're already wearing it, their brain has already learned to fuse the images. There's also something else that is super important. You talked about the age that was there. And this also ties into ethnicity as well. What concern might we have? So you did talk about the fact that they need to get an eye exam because they probably do have an ADPAR. So we can have a conversation with them, you know, also bringing that to the forefront. Like, are you having difficulties reading? Which they may not notice if they're able to function by taking off their glasses with one of their eyes. So they may not actually be having an issue quite yet with that. But and depending if their prescription has changed as well for distance, they may not be having an issue with the reading just yet, but they may be, but they may not. But there's another, oh, glaucoma. Who said it? Yes, Faye. Good job. Yes. Yes. Diabetic retinopathy. Yes. Well, yes, that's the relation why they have to go back for the exam every year. Yes, those are all very, very important things that we need to reiterate to this person when they're coming in as to why they need to go and get an eye exam. Because they may say to you, yeah, go ahead.
But teacher, sorry to interrupt, but you mean like my left eye had the glaucoma and then caused the amblyopia?
No. I'm saying that, so one of the types of glaucoma, and I'm sorry, right now it's not coming to me, is prominent in African American. And then there is African American people as they get older. So somebody who in this situation here already has a significant difference in their eye, and is with a prescription that is now 10 years old, also has diabetes, is also more prone for glaucoma. There's too many risk factors here that could lead to this person losing their vision, right? So Katie talked about the diabetic retinopathy. Faye talks about the glaucoma. All of those things can deteriorate your vision. And outside of that, even if those were not factors, just this prescription alone could lead to them becoming amblyopic if there is a change in their prescription, which there may be because this prescription is now 10 years old. Does that make sense?
Right.
Any questions on this one? All right. Okay. This is a patient's file. Question is, what type of prescription do they have? In the right eye? What type of prescription do they have in the left eye? And my brain is freezing. This is... I think I'm getting tired. Okay, yeah, so they are hyperopic, but what type of astigmatism is it? So, okay, yeah, so minus cell at 180 would give you a width rule, yes, in the right eye. And minus cell closer to the 90 would give you against the rule in the left eye. But no, we're still in the range of against the rule. 20 to the left or right, 20 or 30 to the left or right of 90. 105 is 15 off. So we're not quite in the oblique yet. But in terms of simple astigmatism, simple myopic astigmatism, simple hyperopic astigmatism, compounded, which one would it be? Oh my goodness. My brain is freezing right now. So the left eye is going to be a compounded myopic. The right eye, if you transpose it, it's plano. And now it's not coming to me. The one that's plano. Oh my gosh. Great, my brain is freezing. I shouldn't have recorded my brain freezing. It's the one that's plano. Oh, is it simple? I'm so sorry. Okay, so let's go to the next part and I'll just double check that. Okay, so the patient wants to purchase glasses. Do you have any concerns? Well, you should have some concerns. So find a concern. Yeah.
3-year-old plus and minus OD and OS.
Sorry, say that again?
Sorry, say that again?
3-year-old.
Okay, so the
Is
date
it?
of
Okay, so the date of
birth is
birth is
2017. So you're supposed to
2017.
have
So
two
you're
kids.
supposed to have
They're
two
both
kids.
alive.
Does it plus and minus OD OS?
Yes. It's a plus and minus. So what concerns do we have? No concerns? Anissa Mitchell. Yeah, Anissa. Yeah, they could potentially have vertical balance and they use different material base curve in each eye. Okay. Double vision, yes. Okay. So let me bring it to you this way. Hmm. Let me think about how to say this without giving you the answer. Yes, lazy eye could be an issue. Yes, Katie. That's exactly what I was trying to get at. So in terms of amblyopia, it's preventable in children up to what age? Generally speaking.
Is this one?
Yes, 7, 8. Good job. Sorry?
Is this one amblyopia too?
It's not amblyopia. So the other one wasn't amblyopia. It was a series of things.
The,
It wasn't just
the previous one was amblyopia, right? The previous one.
no, it's not just okay. So let me go back to this one.
Yeah.
So they could potentially get amblyopia because of the difference in their eyes, but they could go blind in either eye because they're diabetic, right? For diabetic retinopathy.
Mm-hmm.
They could go blind in either eye from glaucoma because of their age and they are of African descent. And then they could go blind if their prescription has significantly changed within the last 10 years with that significant difference. Now, this one here is a child. And so when we see children's prescriptions, we have to be super conscious. How often should children get their eyes tested?
Once a year.
Once a year. How old is this prescription?
2 years.
Okay.
2 years.
And then 2 years old, right? Now we're looking at their actual prescription. Somebody talked about the difference of plus and minus. Yes. So again, we want to make sure that we're following this up, that there hasn't been significant changes. But causes for amblyopia in children can be created for a difference of 2 diopters or greater. Is there a 2 diopter or greater difference between the left and the right eye?
Mm-hmm. Okay.
Yeah, we've got a 4 diopter difference, right? From plus 125 to 275, that's 4. If I'm doing my math right in my head, and if I'm not, forgive me. I'm tired. So this child hasn't had an eye exam in the last 2 years. They're only 5 years old, which means when they had their last eye exam, they were 3, which was before they would have started school, more than likely, because they're born more than likely. So we want to make sure that we're protecting their eyes for amblyopia. Another thing that's on here, which you may not realize, is that what the father has is an inherited retinal disorder. And so this child needs to be followed to ensure that there are no issues, because it can potentially, you could potentially have it.
Mm-hmm. Right.
All right. All right, so this is the prescription. And patient is only wearing distance glasses. And they can read perfectly. Recently started having difficulty reading their phone. So what is the most likely reason that they are now having an issue reading? What has changed?
Presbyopia.
Hmm?
Presbyopia.
So they weren't wearing glasses to read before. It was never an issue. They have an ad power there. What has changed?
Aging, probably.
Okay, continue.
After 40 years old, you will get presbyopia, right?
So they already have presbyopia because they have an ad there. Taking
Oh,
off the glasses to read, more minus. Yeah, but you're wrong the right lineup, but what's actually going on here? So how is this person, they have a 2 ad. How are they reading without glasses? They have a 2 ad.
how they read without glasses?
Yeah, they have a 2
But
ad.
because they're basically they're nearsighted, right? They're like myopia. So
Yes, Iris said it. The prescription cancels it out. Yes. So they're -2 in the distance, +2 add. So the reading prescription is actual plan on -25 in the right eye, and the reading prescription in the left eye is +1/4. So do you need a prescription for that to read? No, you don't. So you are right that their prescription has changed and they have become more presbyopic. And so now it's more significant that they're not able to just function by just taking off their glasses. The eye already has plus. I'm guessing you were saying the same thing, Maria? Yeah?
they might need a eye exam again because this prescription belonged to 2020.
Yes.
Is 2 years past.
Oh, okay. Okay. So so in the chat, Katie wrote it -2 +2. So the right eye, the sphere is a -2, and their ad is a +2. So if you were going to make this person a pair of reading glasses, their reading prescription in the right eye, so if you add the +2 to the -2 in the right eye, so this is the right eye here. So we would get plano because that they cancel each other out, and then -25 at 94 for the reading in the right eye. And then in the left eye, if we add the +2 to the 175, we would have
25.
+1/4. Yeah, +1/4. Yeah, +25.
Yeah.
So that's essentially no prescription, right? Like it's very little. Most people with that kind of prescription, if it was a distance prescription, would not be walking around with it. So that's why they were able to take their glasses off to read. But now they're having difficulty reading their cell phone, which means as who's speaking on the speaker? You pointed out whoever was speaking on the speaker. I'm so sorry, your name's not there anymore. The prescription is old, and maybe their reading has increased, right? So maybe now their prescription has increased a lot, and maybe they're a 275 or something for whatever reason, and now they're not able to read their cell phone as clearly. Because now if you put a 275, now the prescription is a little bit higher. Now in the right eye, they're a +1. Question to recheck. Patient later adds colors don't look as bright. Will I be causing this? Yes, potential cataracts, absolutely. So what are you advising them to do? Oh, recheck the eye. Yes, for potential cataract. Good. In addition to all the above information, the patient is also seeing wavy lines centrally. Now what may be the cause?
Macular degeneration.
Yes, you got it. And macular degeneration can also make your colors look faded too as well. So great job. I have another one. Good. Patient's file, patient's history. So this patient is complaining of a burning sensation in their eye, as well as random tears running from their eye. Below is an image of their eye. What condition does this person have, and what's causing it? So they do have a pinguecula, yeah. What else do they have? Yes, it could be. But they said a burning sensation with random tears running down their eye. Dry eyes. Yes. Yes. Dry eyes could be so reaction to solution, it could be burning eyes, but usually with a reaction to solution, you'll see more red eyes. But yes, burning is also a sensation. Okay, so what could be causing dry eyes for this patient? Don't use water. Yeah. Disinfection, usually uveitis. Look at their case file. There's something there. Somebody has hinted to it. Yes. It is the meds, which is the birth control. Yes. Birth control can dry their eyes. So why are their eyes constantly running tears?
Injection.
Dry eyes. Yes. They said it. Yes. So dry eyes, so your eyes over accommodate by releasing more tears. Somebody added a comment about the construction worker. So the construction worker could be the cause for the pinguecula, right? Because they're outside in the sun, UV, dust, dirt. Yeah. Good job. Yes, you already answered that one, pinguecula. Oh, that's why you were talking about water, can't amoeba. I was like, why are you talking about water? Okay, yes, it's in question number 2. Yes. And so question number 2 says, sometimes you rinse your lenses with water. And yes, you should not rinse your lenses with water. And yes, you can get a cantilever. I was like, why are you talking about that? Now I understand why you're talking about that. Good job. And you guys already answered the last question. All right, next patient. What condition do you think the patient might have as a result of their accident? And how would you advise them? Oh, sorry, I think I'm missing some messages. Oh, yes, hyphema. Yes, good job. Yeah, so we checked them on the slit lamp. Yep, they could have a concussion too. That's very true. So advise them to go see the doctor. What condition does it as a result of the accident? How would you advise them? What other potential conditions could they have? Yes, Arcus senilis. And how do you know the Arcus senilis? Yes, cholesterol. And he's sometimes taking it. I had a patient come in and they're like, so we're filling in the doctor's form and they're like, yeah, so I take medication for high blood pressure, cholesterol. Okay, so we should check those off on your medical section that you have those. No, I don't have it. I don't have it anymore because I take the medication. Okay, yeah, but you do have it. That's why you're taking. No, I don't have it. Okay, yeah, fine. You don't have it. I don't know what to say. So he felt like because he's taking the medication and his cholesterol was going down that he doesn't have it anymore. But you still do have it. The medication is just controlling it. All right. How would you differentiate between basal cell and squamous cell carcinoma?
Basal is flat,
Mm-hmm.
and the other one was raised up, like not.
Yes. So what conditions do they have? And are there any indications on their file? Ectropion? Dry eyes. Yeah. Yep. Using lubricating drops, dry eyes. Yeah. What else do you see? I feel like Sanibir, you mean to say something else. Esotropion. Yeah. So eso is in. No. Not esotropion. So what does the prism tell you? Iris is on the right track. Okay, so what does esotropion mean? Because Iris is on the right track. What does esotropion mean? Yes, the eye turns in. So when you look at prism, does your eye go towards the tip or towards the base? Which way does the prism pull your eye? It pulls your eye towards the base. Yes. So if we have a base in prism, I think somebody just wrote it there. I don't want to say your name right. Ruquea? You can come on the mic and correct me. Feel free. Ruquea said it. Exotropion. Yes. Her eye is turning out. Her right eye turns out, so they've given her a prism base in to pull her eye in. Yes. Yes. So we want to pull the eye towards the base. So if the eye is turning out, then we want to give them a base in to pull their eye in, and vice versa. Okay, so sidebar question that relates to this. What is the difference between atropia and aphoria, since we're talking about prism? Yeah, Iris, you're on the right track. Yeah. So atropia is always present and aphoria is latent, so it's not always there. So it may only appear when they're tired or stressed. What about pseudostrabismus? It does have to do with cross-eye. Yeah. So pseudostrabismus is when it looks like somebody has like strabismus, but they don't. Okay, so I have a case, a verbal case to say to you. So a patient comes in, they are wearing contact lenses. Sorry, not contact lenses. Now I forgot what I wanted to say. Shoot. Oh yeah, they are wearing contact lenses, and they've been wearing these contact lenses for a very long time. And they come into you and they say, I don't know what's going on with these lenses. I can't see clear out of my right eye. My left eye is fine. What's the problem? And what would you do? So you're gonna check down the slit lamp, okay. And prism. So prism, what we probably see like double vision, right? So they've been wearing the same lenses, no issues. They've been ordering the same lenses from you for so long. Okay. So what questions do you want to ask me? I don't have any pain. I don't know what's wrong with this lens. I mean, yesterday it was fine, and now today I cannot see out of my right eye. It's blurry. Mm-mm. I'm also feeling the edge of the lens more. So you check me on the slit lamp, there's no pathological issues on my eye. It's the same lens they've been wearing for a long time. Their case haven't changed, so the fit is still good. Lenses are clean, there's no deposits on it. Inside out, good job. Yes. When I say, I forgot to say that first part, feeling the edge of the lens more. When you hear feeling the edge of the lens more, that's a strong indication that the lens is inside out. What's the other one I want to do to you? Let me find it. Let me find the, go back on a second. I need a prescription. Okay, but let's pretend that this prescription is not a kid. Okay, so I fit this person with contact lenses, and I fit them biweekly lens, and I gave them plus 75 in the right eye and plus 250, sorry, minus 250 in the left eye. Minus 225. I'm going minus 225. Minus 225 in the left eye. And they said that so I put them in front of the chart. They can see pretty good. So they leave the store. They come back and they say that they're having difficulty with nighttime vision. They can't read the signs. What do you think the problem might be? Keep going. Oh, somebody wrote it. Why do you say spherical equivalent? What's the problem with the spherical equivalent? I don't have a problem seeing with my left eye, only my right eye. What's the problem? Mm-hmm. Yes, exactly. So generally speaking, when people are over a -1 cylinder, like 125, they generally do need that correction for 0.75. You can get away with that one. Some people not so much, but majority of the population, yes. But 125, yes. The 4-to-1 rule, yes, you can apply that one. But even just generally just looking at the prescription, 125 cylinder, and that's like usually most people over 1 start correcting. Okay, let me go back to the other one. Let me see if there's another. Do I have any more? Oh, that was my last one. That's my last case. Any other questions? It's now 9:30. I'm gonna stop this one too.